It is a great pleasure to participate to this meeting, the 2022 White Sea Symposium in Arkhangelsk. I really missed the opportunity to be there in person with you. In this lecture, I will report some of the evidence on clinical management of subarachnoid hemorrhage. As we know, and this study further demonstrated, there is a huge differences in the clinical management of subarachnoid hemorrhages. And as we see, for instance, the prophylactic use of anti-seizures varies between 10% to 60% throughout European countries, as well as the use of standardized protocol varies between 12% and 52%. So I will try together with you to make a point and to review some of the available evidence, how guidelines changed over time, which are the available evidence on hemodynamic and fluid management, the ventilation, glycemia titration, the role of hormones, and which are the evidences on research and neuroprotection. In a study we published 3 years ago, in cooperation with Paolo Gritti and Sejuna Keju, the current chair of neuroanesthesia at Massachusetts General Hospital, we reported how in the last 15 years, 20 years, there have been published 10 surveys and 11 guidelines. But more interesting, someone that is more aged in this class might remember how in 1994 the triple H therapy was with hypertension, hypervolemia, and hemodilution was considered the standard of care in the treatment of these patients. A few years after, the triple H approach shifted from being a preventive treatment to be a reasonable approach in 2005, and thereafter it was abandoned in 2011. Because there were evidence on how especially excessive fluid administration could lead to an increase of clinical complications. So for now, the last version, 2012, now 10 years ago, do only suggest to use hypertension in patients that present a clinical evident vasospasm. There has been a huge change on the standards, and as we can see now, their indication is to exclude the aneurysm in the early hours after bleeding, and the treatment of vasospasm is effectively associated only with normal volemia, increased blood pressure, and use of nimodipine. So what it remains to be determined is the optimal time. And for now, we know that despite the change in immediate treatment was proposed in 2009, because of the use of coiling approach and the new evidence on the role of the surgical treatment, it is clear that the best timing is early, but not immediately unless the neurovascular team is available. So these patients should be treated in a context of super specialty with dedicated neurosurgeon, neuroradiologist, and neuroanesthesiologist. In some cases, especially in patients aged more than 50 years, it is suggested to wait for the first 72 hours before treating the aneurysm itself. The other unique aspect of patients presenting with subarachnoid hemorrhage is what is called delayed cerebral ischemia. And that was previously known as vasospasm. But now new evidence contribute to show that vasospasm is one of the possible mechanisms that cause delayed cerebral ischemia. So it's important, unless we don't specifically associate with a proven vasospasm, angiographically proven vasospasm, to reconsider this potential risk as delayed cerebral ischemia that might be caused by intravascular coagulation. What do we know about hemodynamic and fluid management? Not too much. This should be clear. Positive fluid balance, as was previously indicated by the triple H therapy, actually predicts a poorer functional outcome. So water balance between intake and diuresis should be based on 2 or 3 hours balance. And also the echocardiographic exams demonstrate that an excess of fluids associate with worsening of outcome. The early goal-directed fluid therapy also shown how at 3 months follow-up, patients treated with the necessary amount of fluids show a better functional outcome than those that were treated with central venous pressure criteria. And daily lung ultrasound might be an alternative approach to monitor if an excess of fluid is administered. It's also important in these patients to monitor the trend in blood pressure and to maintain the blood pressure within values that meet the autoregulation, cerebral autoregulation. So invasive and non-invasive monitoring devices might help in setting the blood pressure at the most appropriate values. So for hemodynamic management, is it clear that positive fluid balance associated with worse functional outcome? Similarly, negative end-diastolic volume and early goal-directed fluid therapy, also using lung ultrasound to predict an excess of fluids in the accumulation in the lungs, might be effective approaches to drive appropriate volemia. The other aspect is to keep arterial blood pressure associated with physiological individualized autoregulation. The role of ventilation. This is specifically the anesthesiologist and intensivist competence, and we should be clear in avoiding even a single episode of hyperoxia with partial pressure of oxygen that exceed 170, because every single episode associate with an increase in delayed cerebral ischemia that doubles and a worsening in the functional outcome at 3 months follow-up. Another aspect of ventilation that should be appropriately managed is to avoid hypocapnia. So excessive volumes, minute volume, is especially dangerous for these patients. And in those patients that present PaCO2 below 35 millimeters of mercury, there is an unfavorable outcome with an odds ratio that goes from 1 to 25 to 133, and an excess of in-hospital mortality. As a possible research initiative, there are some evidence that suggests how in patients presenting a reduction of cerebral blood flow, to increase the PaCO2 might associate with an increase in cerebral perfusion. But so long, these evidence are only preliminary. So the take-home message for ventilation is strictly avoid hyperoxia, and hypocapnia, and consider in future to monitor if there will be evidence that support a therapeutic use of moderate hypercapnia. Glycemia management is a critical aspect of the treatment of patients with acute brain injury, and we know how intensive insulin therapy might associate with an excess of hypoglycemic episodes, but we should also consider that specifically in patients with subarachnoid hemorrhage, the aggressive treatment of hyperglycemia associate with a reduction of infections and a reduction of vasospasm. Hyperglycemia, on the other hand, associate with metabolic derangements with both values above 140 or below 110. So this is the ideal range that we should try to drive our patients through. This is a study, a multi-center studies that we conducted in cooperation with Rome, Brussels, and Valencia, and we have now completed a subsequent study that further confirmed in a prospective manner how cerebral spinal fluid concentration of glucose, glycorrhea, and lactate might have a predictive role in the outcome of patients with subarachnoid hemorrhage. Hormones. Is it well known how subarachnoid hemorrhage, especially of the anterior vessels, might associate with changes in sodium concentration and an increased sympathetic tone? So the clinical prevalence of pituitary dysfunction in these patients might occur in up to 50% of the cases in the first 6 months and persist in 25% of the patients after 6 months. So a dedicated screening for pituitary function should become standard of care and routine in patients with subarachnoid hemorrhage. Trends in research. As we well know, research have largely evolved in the management and possible therapeutic interventions in patients with subarachnoid hemorrhage. I will list some of the latest initiatives, but this is a field that should be kept constantly under surveillance. This is an interesting study that showed how the implementation into a clinical practice of a dedicated team, multidisciplinary team, led to a better clinical outcome in patients with subarachnoid hemorrhage, even though the severity of these patients increased. So it's important for centers that specifically treat patients with cerebral aneurysm to define a dedicated team. The use of dehydropyridinosterone has been tested, but the evidence are not conclusive. And similarly, the use of simvastatin is not supported as a standard of care by available evidence. Another field of research is the administration intraventricularly of tissue plasminogen activator to dissolve intraventricular clots. This study demonstrates the feasibility and the safety of this approach, but there are no sufficient evidence on the effectiveness. So it's still in a preliminary phase. And this is unique for neurosurgery because, as I mentioned, changing the definition of vasospasm from the traditional criteria to the new concept of delayed cerebral ischemia and including the potential risk associated with intravascular clot, the use of non-steroidal anti-inflammatory drugs might have a role. And in this study, there are preliminary results that do support a possible beneficial effect. Similarly, the intracerebral administration of papaverine might play a role in patients that present a clear diagnosis of vasospasm, angiographic diagnosis of vasospasm. Also, the use of inotropic drugs have been tested, and in this study, the milrinone infusion was evaluated for safety when infused intraarterially. Results do support a safety of this approach in patients presenting angiographically diagnosed vasospasm, but no final effects are proven on the overall neurological outcome. Similarly, the use of dobutamine has been tested, and in patients presenting vasospasm resulting into shorter hospital stay, but no differences in terms of neurological function at follow-up. And levosimendan, another inotropic drug, has also been studied for patients with subarachnoid hemorrhage, also considering the effects associated to calcium antagonism of this drug, and prove some preliminary positive results in patients with refractory vasospasm. In conclusion, the treatment of subarachnoid hemorrhage evolved dramatically over the time and showed a counterstream trend. Basically, the triple H therapy has been cancelled by our protocols, and what we now know is that a dedicated subspecialty neurovascular team can deliver a better job in ensuring a better functional outcomes of these patients. Cardiovascular, ventilatory, glycemia, and hormonal asset are extremely important and should be strictly monitored. And my suggestion is also to keep up with the new evidence in research to improve the neuroprotection and delayed cerebral ischemia management. Thank you for your attention.